All right, so now we just have to change gears now and get back into arterial frame of mind. As it relates to, resistive index, RIs, arterial flow patterns, high resistance, low resistance, because that will help us to determine, the absence or presence of disease based on what those arterial waveforms look like. So we're going to discuss the splanchnic arteries. So these, can be referred to as the mesenteric arteries. So these are all the arteries that bring blood flow to your intestines, your guts. We'll talk about the vessels themselves, the characteristics of those vessels, and then discuss a condition called mesenteric ischemia, and then the actual exam that we perform when we're assessing these vessels. So just a little bit of anatomy. You guys have seen these vessels when you're scanning abdominal. So that seagull sign when we're looking at the celiac arteries, that's our transverse view, where you can see the celiac artery coming off the anterior aspect of the aorta, and then the branches, your common hepatic artery and splenic artery. In sagittal, when we were imaging the aorta, you could see the SMA branching off the anterior aspect. You could see the celiac artery branching off the anterior aspect of that aorta as well. When you get a little further distally, we're going to practice in lab, and we'll get the inferior mesenteric arteries. So that's something that you guys probably haven't imaged at all in your abdominal ultrasounds. But we're going to try and find it in transverse, and you can actually see that inferior mesenteric artery coming off. Again, the anterior aspect of the aorta and slightly to the left. But definition of splanchnic vessels, so they include the celiac artery, the SMA, superior mesenteric artery, and the inferior mesenteric artery. So these are the vessels that supply the bowel with blood. We're going to look for the presence of stenosis and or occlusion. So these could be the causes of either acute or chronic ischemia. So when we refer to a condition, it's going to be mesenteric ischemia. So again, these are the vessels that bring blood flow to the mesentery, to the gut. So the condition is referred to as mesenteric ischemia. So it can either be an acute sudden onset, or this could be a chronic condition, a slow development of those atherosclerotic plaques and a slow narrowing of the vessels. So the symptoms vary a little bit between acute and chronic mesenteric ischemia. Acute mesenteric ischemia is a medical emergency. So if all of a sudden blood flow to your gut is suddenly shut off, that's an acute medical emergency. So we're going to see when we get into the duplex examination, you really have to, confirm with the doctor, is this an acute thing or is this a chronic that you're worried about? Because if it's acute, don't waste your time with an ultrasound, send them right for a CT. We need an answer right away. Because the exam that you have to do, it has to be performed fasting and then postprandially, again, after the patient consumes a high caloric drink or they've eaten a meal, you have to rescan them to look for waveform changes pre and postprandial. So if it's really an acute situation, we don't have time to waste, doing that whole process. There are some collateral pathways that do exist. So when you do have disease in these vessels, they can affect one, they can affect all of them, they affect two of the three. But even though, we might have one of these vessels that are completely occluded, the body isn't a wonderful thing. We have these collateral pathways or extra channels that exist to bring blood flow to where it needs to go. So for instance, if my celiac artery is completely occluded and thrombosed and clotted, no blood flow getting through it, we have additional pathways to get blood, if the SMA is still open, through the gastroduodenal artery, that GDA, the vessel that we see in the head of the pancreas, provides a collateral channel. So it's a link between the celiac artery and the SMA. So if celiac is completely blocked, we can still steal some blood from the SMA via that gastroduodenal artery. We'll just have reversal of flow, and it'll act as a collateral channel and dump blood flow into the vessels of the celiac artery. So all those branches that come off the celiac artery can get blood flow from the SMA via the gastroduodenal artery. So this is referred to as the pancreaticoduodenal arcade. Pancreaticoduodenal arcade. So additional collateral pathways that we have, We have this arc of Raylan, which is a link between SMA and IMA. And a marginal artery of Drummond, another link between SMA and IMA. So again, if we have disease in IMA or disease in SMA, and one of them is completely blocked, we can get blood flow into those pathways, those feeding pathways via, again, these other collateral channels. So this was just showing, again, the gastroduodenal artery, straight arrow, acting as a collateral between the celiac artery and the SMA. You have your celiac artery up here, SMA down there. So this acts as a collateral channel between the two. So it connects the two. Then further down, the IMA arteriogram shows portions of that arc of Raylan and the marginal artery of Drummond, the arrowhead. So these also again act as collateral channels or pathways between now the IMA and SMA. I just want to make sure that, like I mentioned, the territories that these vessels feed. It's later on. Okay. So there is a condition referred to as MALS, median arcuate ligament syndrome. So you might see this abbreviation in some textbooks. MALS stands for median arcuate ligament syndrome. This can also be referred to as celiac band syndrome. So the definition of this condition, it's obstruction of the celiac artery. Occasionally it could be the SMA, but it's celiac artery by this median arcuate ligament, producing intermittent symptoms of mesenteric ischemia. So this median arcuate ligament is a fibrous arch that unites the diaphragmatic crux on either side of the aortic hiatus. So basically think of this as a ligament that's attached to the bottom of your diaphragm and connects below the level of the celiac artery. And as you breathe, that ligament gets pulled either taut or gets loose with inspiration and expiration. So it overlies the celiac artery and can actually cause compression of that celiac artery. See if I had like something that was a little.
So it's kind of like visually
Yeah, I'm just looking for
rubber
like a
band
rope.
connected to like
The bottom of your diaphragm.
bottom of diaphragm.
Oh,
To
that totally
your-
rips. It's disintegrating.
Then you have them all.
Yeah. So it's kind of like attached to the bottom of your diaphragm. So if my diaphragm's there and it's attached below it, you have like the celiac artery that's underneath it. So when I exhale and my diaphragm comes up, or like, I'm sorry, yes. So when I exhale and my diaphragm comes up, it's putting tension on that rubber band. So this is fixed down here. The artery is underneath it. And when I exhale, my diaphragm comes up. So I exhale, my diaphragm is coming up. It puts pressure, oh God, I ripped it. It puts pressure on that vessel and actually creates a stenotic lesion. So it creates this fishhook appearance. So we see it in Sarah. So we got a prime example when we start imaging. We can actually see it live. And then when you when you inhale, you take a deep breath in, your diaphragm's going down and it loosens the tension on that vessel. So when the diaphragm goes down, it loosens the tension on that ligament and doesn't compress the vessel anymore. So a deep breath in relieves it. So on her, you can actually see her celiac artery when she exhales, it's putting pressure on that vessel. It creates this fishhook appearance. And when she takes a deep breath in, the celiac artery actually straightens out. It's no longer compressing the vessel. So her velocities go from like, what was it? Did we measure it was like 400 or something? I don't even remember what it was. It was up there. So her velocities, when she exhales, and that diaphragm goes up, it's compressing it. The velocities are very, very high, and then when she takes the deep breath in and it releases, the diaphragm going down, releases that tension. It straightens out, the velocities drop down to normal range,
How does it compress it though?
just where it's affixed
like
and where it's
full?
overlying.
I don't
So
know.
that ligament's going up and down, like with your breathing. And you have, let me see if I have it.
It's like compressing, I'm thinking something's pushing on it. And I'm looking at his rubber band, I'm like.
Well, because behind it is the aorta, so it's being pinched between the aorta and the muscle? Or no?
You pinch between aorta and muscle.
Is that right? No?
No. That's aorta. This is like underneath the base of the diaphragm. It's like, it's affixed, down here along the muscular wall. And then this part is on the base of the diaphragm.
So when,
Okay, go ahead.
And it's a ligament, so this is attached, that's to your, actually more to your spine. So ligaments are like muscle to bone.
so when the person exhales is when it compresses it?
When they exhale, yes, and the diaphragm's going up.
Okay.
So exhale, the lungs are emptying, so your diaphragm's going up. And that's what's pulling the ligament. And then when you inhale, your diaphragm's going down and it's loosening this ligament. So it's not putting that tension, it's not compressing the vessel.
Okay.
With malls. It causes ischemia.
It does, yeah, you're creating a high-grade stenosis in the celiac artery. So all the organs that are being supplied blood flow from the celiac artery, so hepatic artery, the liver, the left gastric artery, so blood flow going to your stomach, blood flow going to your spleen, all get like momentarily, compromised. It's also positional as well. So if a patient's lying down versus sitting up, this can also affect the velocities as well. So with this condition, the characteristics, we look for a marked reduction or disappearance of that obstruction with deep inspiration, and then return of the stenotic appearance with expiration. That's just something for you to be aware of. Surgical treatment, they can actually lyse that ligament.
What is the purpose? So, I mean,
Of the ligament.
yeah, like what is the purpose of that single ligament? I need to know.
You'll be hiccuping for the rest of your life. I don't know. I don't know. I really don't know the purpose of it.
So how is Sarah thriving? Is our other things like
She's not.
giving
How
her
she's
thriving?
She's slowly
When
dying.
does this become a problem?
The what?
When does this become a problem?
When does it become a
Like, Sarah
problem?
seems just-
If you have,
Sarah,
You
are you
will just
fine?
do her-
I mean, again, patients might complain with cramping, epigastric pain, nausea,
She
vomiting, so
doesn't
like,
exhale ever.
No, but that's kind of funny. Not funny, but sometimes I will just randomly get pain and I'm like, ooh, I wonder if my pancreas is okay because that's exactly
where it is.
like the pain is. And like, there's not really anything
yeah.
that helps or it just kind of dissolves. It just dissolves.
No. Deep breath in,
Gotta hold your breath for a
Like-
while.
Yeah. nice deep breaths. So patients that do suffer from median artery ligament syndrome or celiac band syndrome, that celiac artery has this classic fish hook appearance to it. So you'll see it have this, curvature to it. And then, like I said, with that deep inspiration, that'll straighten out and you'll no longer have those fast turbulent velocities. So with this, when you're Doppling, you could see aliasing, you see the fast flow, the turbulent velocities. So here was an example where they were Dopplering, where they measured, this is like almost 300 centimeters per second, or 320 they measured. And then with the deep inspiration, it drops down to, like 120. So you're within that normal range now.
Does that increase, increase her chances of having some sort of, and could that cause like, the celiac trunk to, become an aneurysm, like dilate
Yeah.
because of all that pressure
Yeah,
building
it
up?
could. It could create over if, she was a chain smoker and had a bad diet. You could develop plaques there easier.
Diet.
You see what's next to her?
The dynamics
But-
are fine.
But yeah, if you're creating a stenotic lesion there every time you breathe. Was it Sydney also we discovered has it as well. So like when we were possibly, I wanna check, maybe.
So it's everybody who's skinny. Gotcha.
You just can't, we all have it, you just can't tell. 'cause you
Yeah,
can't
yeah.
visualize it.
Gassed out.
But with Sydney, she also has underlying liver issues. So like with her, like I told her to talk to her doctor, because she has abnormal liver function tests. I'm not entirely sure about her whole medical history, but she told me she's got underlying liver issues. So that she sees a hematologist about. And like her liver enzymes have been elevated recently, so like she's making another appointment, but like, I'm like, mention that to them, go get further testing, because you don't want to compromise blood flow to your liver, if this is like an ongoing thing and you gotta protect your liver, you're so young,
We don't have insurance then.
Yeah, that part.
She might still be under her parents, I don't know.
Oh, yeah, she's
Yeah.
young enough to
Yeah.
be still there, yeah, true. Remind me old vision.
You're old. So this was a 28-year-old woman with abdominal pain. The velocities, were elevated with inspiration and expiration. So with this, they were doing the inspiration, expiration, and they were still obtaining elevated velocities. So it's important to actually change the position, have them sit erect, sitting up, and see if that improves. With supine, so indeed, it shows the narrowing and the turbulent flow at the origin of celiac axis with the patient in the supine position. But when they sat him up in the erect position, this improved. We were able to get a normal velocity measurement, with them actually sitting up. So it can also be positional. Again, with this supine, elevated velocities, and then when they sat him up and scanned him in the erect position, then those velocities normalized and you saw a significant reduction. So these velocities are high. This is over 500, almost 600. So with inspiration and expiration, they were both, significantly elevated, but then returned to normal when we sat the patient up and then scanned him standing up, or not standing up, sitting up. Any questions about malls? I like to say celiac band syndrome. It's easier to memorize
Yeah,
and remember.
Names again. Mesenteric artery.
Median arcuate ligament syndrome.
Oh.
Mall. Celiac band syndrome. All right. So the actual arteries and their characteristics. So celiac artery, or celiac trunk or celiac axis. We know it's got three names. Branch off that celiac artery, we have our splenic artery. We're also gonna discuss superior mesenteric artery and inferior mesenteric arteries. Cause this one is a branch off of this celiac, so these are three main ones. So when we eventually wanna rule out mesenteric ischemia, those are the three vessels that we're assessing and interrogating and looking at. And we'll see in a moment, like, in order to make that diagnosis of mesenteric ischemia, two out of those three have to be, stenotic. Or there has to be disease in them to make that diagnosis of mesenteric ischemia. General anatomy for celiac artery. So this is the most cephalic branch of the abdominal aorta. We know this is the first branch that we see coming off the abdominal aorta. It bifurcates into our common hepatic artery and splenic artery. And then the left gastric artery arises off of that. Supplies the liver, pancreas, spleen, stomach, and the proximal small bowel. So we see this in that transverse where we could see that T or seagull sign. So in terms of resistance, what does this waveform look like? High resistance, low resistance. Low resistance, definitely, because this is, again, supplying blood flow to our organs here. We see a bunch of organs listed there, liver, spleen, pancreas, stomach. So we need low resistant blood flow in this vessel. The velocities, so with this vessel, we could see an increase in velocity after the patient eats. Why? Why do you think?
So your gut needs blood to
Yeah.
process your food.
Yeah, definitely. Stomach needs blood, liver is doing its work, needs blood, pancreas is working, so yeah, these organs are working. So we see an increase in flow after patients eat. So normal velocities now. Gotta star these, we gotta know our normal velocities, so it should be less than 200 centimeters per second. So anything over 200 is considered stenosis or stenotic. Two 200 centimeters per second, that's our magic number for celiac artery. If we see areas of stenosis, we're trying to find that localized area of high velocities. We might see post-stenotic turbulence, so aliasing of the color flow. When we Doppler it, we see turbulent flow filling in of your spectral window. If we see a dampened waveform, it might be a high-grade stenosis further downstream, so further along the course of that vessel. And then that celiac artery velocity criteria table. So again, anything over 200 centimeters per second is considered stenotic for the celiac artery. You guys have seen this picture, you know, in your ultrasound scanning and in your textbooks. It's our transverse aorta with the celiac artery coming off anteriorly and then branching that common hepatic artery going to the right towards the liver and splenic artery going out towards the patient left. So in lab, we're going to practice, you know, getting this image, trying to Doppler celiac artery, try and Doppler splenic artery, try and Doppler our common hepatic artery, obtaining our peak systolic and end-diastolic velocity. So with these vessels now, since they're going to our mesentery, they're going to organs, we need to obtain both peak systolic and end-diastolic velocities. So in terms of velocity criteria, I'm not too worried about end-diastolic velocities. What we're worried about is this peak systolic velocity, so greater than 200 centimeters per second. That's what the boards test you on. That's what I'm concerned about. So greater than 200 centimeters per second is considered stenotic. So here we can see a patient with celiac artery stenosis. So first thing you notice, We see aliasing, turbulent flow in that celiac artery. It's got some curvature to it as well, so maybe this is a patient who has median arcuate ligament syndrome. When they Dopplered, velocity is 555, so it's, markedly elevated. And another picture now. So now when transverse aorta, we see the celiac artery coming off. Again, we see very turbulent flow, all this aliasing going on with elevated velocities. Another case, celiac artery stenosis. So you got fast elevated velocities, they Dopplered a little further along in that celiac artery, and now we have targus parvus waveforms. So we know that there's some sort of high-grade stenosis. So if you're Doppling, say you can't see the origin of that celiac artery very well, and you Doppler and you get targus parvus waveforms, it's safe to assume that there's a high-grade stenosis somewhere causing that targus parvus waveform. So again, you guys as vascular techs, just try and get as much information as you can, and then put those pieces of the puzzle together. Another patient, celiac artery stenosis, elevated velocities. See a turbulent aliasing with the color Doppler. And some post-stenotic turbulence from that second waveform. So anatomical variants of the celiac artery. So not everyone's gonna have a nice Siegel sign. Rochelle, her hepatic artery, I think we decided connected to her SMA. Yeah, so she was like this guy. So we were following, trying to figure it out. And it was a little tricky, and we're trying to scan, but like, I see the hepatic artery, beautiful, but we couldn't connect it back to her celiac artery for the life of us. We're scanning, trying to figure this out. And we find out that it actually connects to her SMA.
She doesn't have a celiac artery.
She does. We see splenic artery, we see the celiac artery coming off, we see the splenic, beautiful. We couldn't really visualize left gastric, but we just couldn't get the one branch, so we were joking that like her seagull was flying in circles because it only had one wing. So it was like that was our joke. But yeah, we eventually found it connecting to her SMA. So this is just for you guys to keep in mind. Anatomical variants do exist. And then you have to kind of just, if you do have anatomical variants, you're transverse, midline, trying to get a nice Siegel sign, you can't get it, you're not visualizing the vessel, work your way in reverse. Start at the liver, find your, proper hepatic artery and just work your way back out towards midline. So kind of just go in reverse, see where that vessel goes. Because again, all roads kind of lead to home, you can track vessels, you can follow along their course, see where they end up, see where they originate. So as with any artery, vessels can become aneurysmal. So this is just showing a celiac artery aneurysm. So a large dilated segment of that celiac artery. So hepatic artery. So we know the hepatic artery now is going to be anterior to that portal vein. So we're going to be looking also to Doppler the hepatic artery in this next comp. We're going to work on trying to open up the hepatic artery, obtaining a nice spectral Doppler waveform. So this was just showing hepatic artery in relation to common bile duct, in relation to portal vein. So this is where you guys are a little, have that advantage over, the CDS students in being able to recognize, you know, hepatic artery, CVD, bile duct, portal vein. You guys are good. You guys can find CVD.
I still struggle with CBD. Like it's this for.
So with these photos, again, you can see your main portal vein, anterior to your portal vein, you have your bile duct, common bile duct. Here's your right hepatic artery. You can see bifurcation to right and left hepatic arteries. And then you can try and open it up. Splenic arteries, or splenic artery, so splenic artery, the word that you want to kind of make synonymous with splenic artery is the word tortuous. So if you get any questions about this vessel, this abdominal vessel is tortuous, and oh, you can stop right there, it's splenic artery. So with the splenic artery, think of it kind of coiled and very, very taut, very tortuous. Because of that tortuosity, we were doing some review questions, it's more prone to developing aneurysm because of those tortuosities. But it courses along the posterior superior margin of that pancreatic body and tail. Gives rise to the pancreatic branches, the short gastric branches, and the left gastropycalic artery terminates at that splenic hilum. So it should be low resistance. Again, it's bringing blood flow to an organ now. We have nice continuous forward flow. So this was trying to demonstrate a splenic artery aneurysm. So we're at the hilum of the spleen in our sagittal view. You can see a large, what looks like anechoic structure in there that actually represents aneurysmal splenic artery. You guys actually want to see a tortuous splenic artery scan angio. His splenic artery, when you're midline like that, you see this thing going like it's bananas. Like it goes and goes like it turns all around. So the next main vessel,
What's the top velocity for the splenic arteries?
for stenosis, there isn't a set criteria for like a concerning stenosis.
Yeah, that's stenosis.
Most of the stenotic lesions are gonna be at the origins of vessels. So with these splanchnic vessels, it's gonna be at the origin of the celiac where we see most of our stenoses and blockages. If you had to just focus on the splenic artery, then you would use a velocity ratio where you'd see a doubling of velocities between segments. But that's gonna be pretty rare to just have stenosis in that splenic artery itself. Most of the stenoses are gonna be here in this area at the origin of the celiac artery. That's where we're gonna see the vast majority of the blockages.
Yeah, I was gonna say, you just Doppler, like, you see this for the first,
Yeah, so we're gonna be Dopplering, yeah, exactly. We're gonna be Dopplering,
multiple spots.
no, for splenic artery, not just one. Yeah. So SMA. This also arises off the anterior surface of the aorta. It's parallel and lies to the left of the superior mesenteric vein. So if you do get those anatomy questions on the boards comparing SMA and SMB, just think it's the same orientation as your aorta and IVC. Aorta is to the left, IVC is to the right. Superior mesenteric artery is to the left, SMB is to the right. So it lies to the left of the SMB. So it's the same orientation as your aorta and IVC. In terms of the supply, the territories that it supplies, I think the right patient's right side of their intestine, so all the intestine that lies on the right and up until midline. So transverse colon, the ascending colon, jejunum, ileum, cecum. So the ascending colon, the proximal 2/3 of the transverse colon, the duodenum, and the pancreatic head. So all the things on the patient's kind of right side, so from like here over. Picture. I not have this one at this point. So we can recognize the SMA by its distinctive triangle mantle of fat that surrounds the vessel. So this serves as that landmark. This is what creates that characteristic target sign or bullseye that we see. The pancreas and the splenic vein lie anterior. The left renal vein lies posterior to this vessel, so it's that left renal vein courses in between the SMA and the aorta. So that's its normal presentation. You might see some mild turbulence near the origin of the aorta with this vessel. Just because, you know, you have your main aorta and just that branching off immediately. But it should return to a nice laminar flow once you get away from that immediate origin. So with this vessel, one of the characteristics is that it changes its resistance based on whether the patient is fasting or they've just eaten. So preprandial, when they're fasting, we should see a high resistant flow pattern. Because basically, you know, the intestine doesn't need its blood supply right now. It's not in the process of working to digest our food. But after we've eaten, we need that increased blood flow, so it changes to a low resistant flow pattern. So that's needed for digestion. Again, we said we have that communication between the SMA and that celiac artery via that gastroduodenal artery, or that pancreatoduodenal arcade. So think GDA, gastroduodenal artery or pancreatoduodenal arcade. With SMA stenosis, one of the ways we can diagnose this is if we see a low resistant flow pattern, even in that prefrontal state. So that's why it's very important when you're doing this study that the patient truly is fasting and they're truly MPO, because that could skew your results. If we also see any abnormally high velocities and post-night turbulence, this can also lead to that diagnosis of SMA stenosis. And with this, we also have a velocity criteria that we'll see in a moment. So this is showing the SMA as it comes off, and then all the branches off the SMA and the kind of the territories where they bring blood flow to. A nice transverse view, so we all know this picture by now. Let's see if I can get Brian to text a picture. Did you guys see the picture of Brian superimposed over this image?
Yeah.
I showed you guys, yeah. It like lined up perfect. Like, so he stood up here and like in front of this and like
Oh,
it
yeah.
showed exactly like the territories where the blood flow was going. So it's got a nice, you know, visual that shows where all these branches are going to the intestine, what segments of the intestine that the SMA actually feeds. So basically it's like, you know, all the intestine on the right side, transverse colon coming across, stomach. So in sagittal view, we get a nice picture of the SMA coming off the anterior aortic wall onto this is, our best window for Dopplering. We're gonna get, our best Doppler angle for, the SMA. For our comp, we're gonna practice Dopplering proximal SMA near the origin, then we're gonna try and follow it a little bit more distal, get a second velocity measurement for, mid SMA. And this just shows the difference, between pre-prondal versus post-prondal. Someone who, is fasting, has a nice high resistant waveform versus, the difference you see after a patient's eaten. There's a definite obvious difference in our waveforms. So again, if we see a low resistant waveform after they've eaten, this could indicate, stenosis or presence of disease in the SMA. I'm sorry, did I say that? If we see a low resistant waveform, pre-frontal, if they're fasting and we see low resistant waveform, that can indicate the presence of disease. Sorry. So we expect to see high resistant if they're fasting. So velocity criteria. So don't worry about the end diastolic, just our peak systolic. So this one's 275, yes.
Why would it be high velocity if they're fast?
Why would, not high velocity, low resistance. So that low resistant waveform could potentially indicate a stenotic lesion. So when we have stenotic lesions, we get increase in both end diastolic and peak systolic velocities. So stenotic lesion will create a low resistant waveform. So when we have stenosis, we get low resistant waveforms.
Okay, I guess I'm just confusing it because I thought low resistance was good. For all of them.
It's good if we've just, for this one, it's good if we've just eaten. So like, this could, if they could either just be lying to us, like, yeah, I'm IPO.
Check their gallbladder.
Yes, you guys could, check their gallbladder.
And
If they have one.
If they have.
Yeah.
But in terms of velocity criteria, 275 is our magic number now for SMA. So over 275 is considered stenotic.
You love low resistance, just the SMA if they're fasting. Or low resistance overall.
If they're fasting, it should be high resistance SMA. If they're fasting, it should be high resistance. If they've just eaten, then it's low resistance.
Okay.
So that's the normal response. High resistance if you're fasting, low resistance if you've just eaten. That's the normal response we're looking for.
In general, or is that just for SMA?
SMA and IMA. So those two are gonna be act exactly the same way.
And the rest of them. We want.
Low resistance. So celiac, you want low resistance all the time. Celiac doesn't really change resistance. Celiac stays the same, whether you're fasting or,
And the SMA. And
Or
you said
eating.
The SMA and what other one?
IMA, inferior mesenteric
And
artery.
they change because they feed the stomach.
Yeah, the gut, yeah, stomach gut, yeah.
Okay.
The celiac artery, you can have more flow, so the velocity's gonna go up a little bit if you eat, but the resistance shouldn't change. You shouldn't have any change in resistance. So celiac was 200 centimeters per second, SMA 275. This was just showing some, again, stenosis for the SMA. So we can get in the color, you see the turbulent flow. Velocity is 283, so that's over our threshold. A little further down, we get post-stenotic turbulence, so we can see the waveform below the baseline, that mirroring, representing turbulent flow. And this one, 300, so again, that's over your threshold. So the color on this is terrible, God, it's all bleeding out, but they're just trying to demonstrate again turbulent flow within the vessel. This is a very rare occurrence, where it's called SMA syndrome. So we get compression of the duodenum, by the aorta and SMA. So in this case, these patients lack that, echogenic mantle of fat, that, surrounds the SMA. And because of that, we can get compression of the patient's duodenum between the SMA and the aorta. So this can have a very high mortality rate to it, about 1 in 3. Symptoms include nausea, vomiting, stabbing, abdominal pain, advanced malnutrition, could lead to GI bleeds. Or Wilkie syndrome, SMA syndrome.
So it's just compression.
Compression of the duodenum by the SMA and the aorta. So these patients are lacking that echogenic mantle of fat, that mesenteric fat that typically surrounds the SMA. So this is what gives it that bright echogenic appearance that we see, that fat that surrounds the vessel. So it's lacking that, and now the vessel compresses between the two. Let's see, celiac artery and SMA. That's a nice clear picture.
That's not all for sale. I guess it is.
Could all be so clear.
It's not real. Oh,
Mhm.
so what is CGI? Or maybe he's being happy. I heard you're clear.
So again, I just want you guys to be able to recognize your vessels on ultrasound. So you have to be able to recognize sagittal aorta, recognize SMA, so you can see again, the echogenic mantle of fat that surrounds the vessel. Got your celiac artery also coming off the anterior wall, so be able to label celiac, be able to label SMA, recognize them. Then the last vessel is our inferior mesenteric artery. So now this is providing blood flow to the distal colon and proximal rectum. So left side of the patient, that descending colon, the distal colon, proximal rectum. So midway between the renal arteries and that aortic bifurcation, this vessel also arises off the anterolateral aspect of the aorta. So it's a little more lateral to the left, but still off that anterior wall of the aorta. This also has similar characteristics to the SMA in terms of its resistance. So if you're fasting, it's high resistance. If you've just eaten, it reverts to a low resistant waveform. This has, we said, collateral branches between the SMA and IMA in cases where we have obstruction or disease in one of the vessels. So those collateral pathways are that the arc of Ryland or the marginal artery of Drummond. In terms of finding it on ultrasound, so we're gonna get a little practice in trying to find it. We're gonna be coming down the aorta and transverse, and we're gonna be looking for a small vessel in transverse, so a small little circle anterior to the aorta and slightly to the left. So this is gonna be a little further down, so eventually this is gonna come up and connect, and probably branch. You'll see it connecting into the anterior aortic wall.
You said this is like mid aorta?
This is more distal aorta, so this is between where the renal arteries come up and that bifurcation, so
So between,
probably just above your belly button, so,
so right below renal.
yeah, below renal,
Inferior.
yeah, renal. So your renal arteries were, so renal, is it on here?
Yeah.
Yeah, they're on, so that's IVC. The renal arteries are gonna be, right around here, so there's your bifurcation, IMAs kind of distal. Pretty distal. So this is showing a waveform fasting, because it's high resistant. We can see, it's triphasic, high resistant waveform, so a normal flow pattern in someone fasting. So here they utilize some contrast to actually be able to visualize, the IMA. So again, you can see it coming off that anterior left, aortic wall. Normal, high resistant, Doppler waveform fasting patient. All right, so velocities, 200, greater than 200, considered stenotic. That's what I want you guys to know. So don't worry about the normal ranges. Just recognize over 200 now for IMA. So it's really easy for these three vessels.
Okay.
Celiac artery 200, SMA 275, IMA 200. So 200, 275, 200. 200, 275, 200. 200, 275, 200.
Yeah, it's gonna pop up in our bedrooms at night while we're sleeping. 200, 275, 200.
Sounds like, what's the guy who bids, like the person who's saying the bidding. I forget what they're
Hey, can I get you 75,
Yeah.
200, 200, do I have 200 here, 200, 25, 200?
There is a name for them and I can't.
There
remember.
is a name for that, and I saw it on TikTok with how they like learn how to say that, and I was just like, oh.
From Busta. Clearly.
Stripes. This is serious.
Auctioneer.
It's dangerous.
He would have auctioneer, right?
Auctioneer.
He would have been an amazing auctioneer.
I remember the Micro Machines guy when I was growing up.
Oh my god.
Remember that guy?
I love micro machines.
Guy who talked really fast. That was like his one calling in life. He could talk fast. He was famous for a while.
He was.
Until he died.
Did he?
I'm sure. That's a
At this
long
point, yeah, you're right. We're talking like.
Machine.
I've never seen a micro machine. Don't you have a little brother?
They still make them?
Yeah.
Do they? Wow.
It's a tiny, tiny matchbox car. They're like so little. They're adorable. They're like
Yeah,
this big. They're so cute, and a lot of them are like monster trucks.
Have you seen Home Alone?
You see like the monster truck.
Huh?
Like Home Alone, he puts all the little Micro Machines like on the floor, and that's what the guy like slips on, and it's the little
It
cars like
was
that.
huge back in the olden days,
Yeah.
before there were cars.
Yeah.
So had horse and companies.
I wish I had like my like some of those toys from back then. They're worth a lot of money, like Teddy Ruxpin and
Yes,
like
they are.
Teddy Ruxpin freaked me the fuck out, and I wanted no parts of it. My mom.
I know, I remember at that point, I was like, wow, this is like AI, like.
It was the scariest thing on the planet.
Isn't that crazy now? That's crazy to think.
Yeah.
Now they have iPads.
No, they have iPads. All right, so IMA stenosis. So again, you're looking for signs of turbulent flow. We're gonna work on getting a good Doppler angle, trying to connect this vessel back to the origin, back to the aorta. Because again, that's where your stenotic lesions are gonna be. They're gonna be at the origins of these vessels. That's where your most likely spot is if there's gonna be a stenotic lesion. So this case, we have very elevated velocities, 383, representing the stenotic lesion. In most cases, it's just atherosclerosis. Yeah, so buildup of those fatty calcified plaques, atherosclerotic lesions
And
developing.
just those symptoms, essentially.
I'm sorry?
I said in those symptoms to make that atherosclerosis is just.
Yeah, your risk
continues on
factors.
to the stenosis. Yeah.
Yep.
Gotcha.
So these patients might also have aortoiliac disease, if they have stenosis in these vessels, they probably also have aortoiliac disease. I know my 91-year-old grandmother had mesenteric or has mesenteric ischemia. Her celiac artery was like 90% blocked. SMA was completely occluded. They couldn't even see IMA on her scan, so they had no idea what was going on there.
She's not even around.
I talked to her about it. Like, I was like, well, you got a couple options here,
comfortable or?
And get me.
So they stented open her celiac, got it to like 50% open from what it was, which is a marked improvement. But she was having like digestive problems. She was like, I'm getting all this reflux. I'm like, it was, couldn't, stomach pains and all this and like, I don't know, I think it was off another scan that another doctor noticed this, and then she went in and they did a catheterization over Christiana, try and open it up, and so they got it to open up a little bit more. So her symptoms definitely improved, like in terms of eating, because she wasn't eating anything at that point. But yeah, I don't know. So- Oh yeah, so that's kind of segueing into like mesenteric ischemia. IMA stenosis. All right, so mesenteric ischemia. So mesenteric ischemia, we said there's two different kinds. We have acute mesenteric ischemia versus chronic mesenteric ischemia. So acute mesenteric ischemia is sudden onset. So someone who's never had any symptoms before, no complaints, no digestional complaints, no issues with anything. And all of a sudden they develop, severe symptoms, severe pain, nausea, vomiting. We'll see with this acute mesenteric ischemia, they typically evacuate their bowels. All of a sudden they have no control over their bowels. Versus someone who's got chronic mesenteric ischemia. So it's that slow buildup of those atherosclerotic plaques. And they have, persistent symptoms that they've been going on for a while, and they've eventually gotten to the point, where it's intolerable. We'll talk about the diagnostic criteria, the clinical significance, what constitutes, a positive result with mesenteric ischemia, and then the Doppler diagnosis and findings. So mesenteric ischemia, with acute mesenteric ischemia, this is acute arterial occlusive disease. So if it happens suddenly and it's not a result of those atherosclerotic plaques, it's the vessel being blocked most likely by some sort of embolus or that vessel becoming suddenly thrombosed. Other things that could cause it would be sudden external compression. So if it's a clot that's blocking these vessels, the most likely source of arterial embolus is from the heart. So it's most likely some sort of clot that was in the heart that got ejected from the heart and then found its way into one of these vessels, is now obstructing the vessel. So with, again, acute mesenteric ischemia, sonography is not very useful. So we need to get in there fast. We need to, remove this clot, thrombolysis, extract the thrombus, and reperfuse this vessel quickly. So if it's non-obstructive mesenteric arterial insufficiency, this could be caused. If it's not an obstructive lesion, it could be caused, by hypotensive shock. If the patient has very low blood volume or sudden blood loss, or even sepsis, that causes insufficient blood flow to the bowel. That could be another cause. There could be veno-occlusive disease. So with this, ultrasound plays a lesser role due to the limited ability to detect slow venous flow. And then with chronic mesenteric ischemia, again, this is the development of those atherosclerotic plaques affecting the arterial vessels, creating those stenotic lesions. So with acute mesenteric ischemia, it's again, sudden onset of those symptoms that can lead to a life-threatening condition. So acute mesenteric ischemia is life-threatening. That's why it's considered, a medical emergency. They present with abdominal pain, bowel evacuation, abdominal distension, fever, dehydration, acidosis, could eventually lead to death. So again, this is considered a surgical emergency. So with this, CT is the preferred method of diagnosis. So you're not going to waste your time trying to do an ultrasound, make sure they're MPO, and then, go through the whole process. You're going to go right straight to a CT. So if you ever happen to be working evenings, overnights, they want you to rule out mesenteric ischemia, you like ask them, oh, is this chronic or acute mesenteric ischemia you're worried about? Because you might have a resident or someone in the ER or physician assistant PA. Oh, let's order an ultrasound for this, when it's a critical emergency, like, no, you guys need a CAT scan. So go to your attending, go to your radiologist, be like, they want to rule out mesenteric ischemia. Is this, acute versus chronic? Do we need the ultrasound or should they go for a CT? Majority of the time, you can probably pass this off to a CT. It's just you're gonna get a better exam.
You just gotta talk to the doctor.
Talk to the doctors, yeah. So like, rather than you just trying to do it, talk to your doctor before you go down that road of just doing the exam. Talk to your radiologist. Be like, are we doing an ultrasound for this or should we do a CT?
What's the exam exactly?
To rule out mesenteric ischemia. So if you get an order that says rule out mesenteric ischemia
Yeah.
from the ED late at night, talk to your radiologist, before trying to do that, embark on this, So where ultrasound comes in, so we really don't touch it if they're worried about acute mesenteric ischemia. We could do it if it's chronic mesenteric ischemia, because again, this is secondary to those atherosclerotic narrowing or occlusion of those major vessels. So the symptoms with chronic mesenteric ischemia, these patients have postprandial abdominal pain. So after they eat, they develop abdominal pain. They could have substantial weight loss because there's poor blood flow getting to the intestines, so they have poor digestion of the food. So they're not really absorbing the nutrients properly. So they have weight loss. They might be the presence of an abdominal bruit. So if we have stenotic lesions, those are causing turbulent flow. The doctor's, listening with the stethoscope to their stomach, to their abdomen for bowel sounds. They might hear a bruit because of the stenotic lesion in one of those vessels. So with this, we have more options now, since this is a chronic condition. You could do the ultrasound, they can do CT, they can do MRA, angiogram. So with ultrasound, so assessment, we're gonna do assessment of flow resistant patterns in the fasting patient first. We're gonna do duplex to detect the presence of stenosis or occlusion. So again, clinically significant diameter reduction greater than 70%. That's what we're looking for. So that's why I told you guys, just memorize those peak systolic velocities. Because really that ultimately is what's determining, the presence or absence of mesenteric ischemia. Yeah, 200, 275, 200. And in order to make that diagnosis of chronic mesenteric ischemia, it has to follow the 2-vessel rule. So we have to identify 2 out of the 3 splanchnic arteries being stenotic in order to have a positive diagnosis. So that could be a little bit tricky if we've not seen vessels. So for instance, we could see celiac artery, that's fine. We see SMA, that's stenotic, but we don't see IMA. We can't make that diagnosis because we can't call 2 out of 3. We're just seeing 1 out of the 2. One of them is positive, one's stenotic, but we don't see that 3rd vessel. So unfortunately, us with ultrasound can't make that diagnosis. So we need to have 2 out of 3 positive. So the color Doppler diagnosis of chronic mesenteric ischemia. So we can see luminal narrowing. So we see those stenotic areas that are calcified. We see narrowing of the lumen. Colorful aliasing. So color Doppler is our best friend when we're doing these abdominal Dopplers to visualize the vessels. We look for aliasing, color bruit artifact. We're searching for those elevated velocities with our pulse Doppler interrogation. Looking for, again, signs of post-stenotic turbulence. We could look for signs of tartarus parvis waveforms. If we see a segment of the vessel distal from the origins, look for tartarus parvis waveforms. Maybe the presence of any collaterals. Then the keys to this is adequate patient preparation. So ensuring that they're fasting, they're truly NPO, having good equipment. So if you're trying to do this with a little portable machine, God bless you, good luck. It does take a little bit of experience. So it's not, the easiest exam in the world, but a little practice, you can definitely get the images. But we do, if we're able to get quality images, we have very high diagnostic criteria. And we can make that diagnosis. Sometimes they also order the additional studies to correlate what we're seeing. Grayscale evaluation, we were able to see those atherosclerotic plaques and or thrombus. We might see reversal of flow, the presence of color buoys as additional criteria or signs of significant disease. Again, in terms of preparation, they need to be fasting for at least 12 hours, so preferably overnight. Position, we have them supine, quiet respiration. We could try decubing the patient, come from oblique positions. We're going to utilize our grayscale color Doppler. We're going to use our curved linear array. So with this, again, we could identify conditions like median arterial ligament syndrome. We can evaluate for chronic mesenteric ischemia, evaluate any collateral vessels. In some patients, you might find they might actually have mesenteric artery bypass grafts. So this could be, advanced vascular surgeries where they're actually bypassing occluded vessels in order to provide flow to the mesentery. And then your limitations are all the things that would limit, your abdominal ultrasounds, bowel gas, body habitus. So in terms of our protocol, we're going to evaluate the abdominal aorta with grayscale and color Doppler. So we're going to look for any plaque within the aorta, any elevated velocities within the aorta. So if we have elevated velocities or reduced velocities in the aorta, so for instance, if it's aneurysmal, we're going to have reduced velocities that could skew our velocity measurements within those splanchnic vessels. So we obtain Doppler waveforms at the level of the mesenteric arteries for our aorta. Evaluate the patency, Doppler waveforms with velocity measurements of the celiac, SMA, and IMA. We're gonna Doppler, moving our cursor from the origin to visualize segments of those mesenteric arteries to search for those highest peak systolic velocities. So again, don't just if you demonstrate elevated velocities or what looks like elevated velocities, sample around. So slowly move from the origin and slowly work your way distally, searching for those highest velocities. So this is aorta at the level of the celiac artery and SMA. So with this, we have a highly calcified aorta. So here's your aorta and sagittal. You can see a lot of calcification, a lot of posterior shadowing. So if you see an aorta like that, the likelihood is there's probably also atherosclerotic lesions affecting your splanchnic vessels as well. So this is now a patient with a large AAA. So since the majority of AAAs are going to be infrarenal, below the level of the renal arteries, this might affect or will have an effect on your inferior mesenteric artery potentially. So it's also part of the protocol. You want to evaluate splenic artery and the common hepatic artery. So when we Doppler celiac, we're also going to interrogate the splenic and common hepatic. You want to note flow direction in the common hepatic and gastroduodenal arteries. Because again, these can act as collateral pathways now, particularly at GDA. Evaluate the patency of these vessels. We're also going to look at the superior mesenteric vein, splenic vein, and main and portal veins as well. We're gonna, while you're scanning, you're gonna examine the liver, gallbladder, pancreas, spleen, kidneys. Look for any para-aortal caval adenopathy, so any enlarged lymph nodes surrounding the aorta. So these are your mesenteric lymph nodes. Doppler, make sure that you have proper Doppler angles to evaluate these vessels. So they can be used, look at any previous exams as well to try and mimic the Doppler angles that were utilized on previous exams for follow-up examinations. Alright, so again, repeats the solid velocities. 200 for celiac, 275 for SMA, and 200 for IMA. That's really what I want you guys to memorize.
The boards, do you need to know the end solid?
All the board's questions we've done have never asked about anti-style. I haven't
Okay.
seen that on any of the review books that we've been doing. Because this is what constitutes mesenteric ischemia, greater
Yeah.
than 70%, so that really, that's the number that you wanna to know.
Remember?
Yeah, that, you're doing this to rule out mesenteric ischemia,
Yeah,
so.
Okay.
Ta-da. Pitfalls. Well, yeah. You guys don't have to memorize all these pitfalls, just realize, you know, you could encounter anatomical variants, so it could be a little bit tricky scanning, trying to figure out what vessel is what. Um. Patient could potentially have median ocular ligament syndrome, you know, causing those elevated velocities. You might have low flow or low velocities in those mesenteric arteries. That may be due to an aneurysm. When in actuality, those vessels appear stenotic, so you might see something that looks pretty calcified, looks narrowed. But the velocities aren't high because they have an aneurysm, the aortic aneurysm, so the velocities are so slow in the aorta. The slow velocities proceed on into those mesenteric vessels, which again, be careful of that. If they have cardiac arrhythmias, you might have variable systolic velocities because of those cardiac arrhythmias. You might have some that peak high and then some that are really low. So in that case, you kind of pick in the middle of the road, pick a waveform that's in the middle between ones that are really high versus waveforms that are really small. So arrhythmias, again, could cause issues.
that's that when they're like hooked up to that one machine, right?
Aortic balloon pump. Yeah, so if they have an aortic balloon pump, it's gonna look really funky. Chances are that, well, I don't know. They're probably not too worried about this at this point. Well, maybe, I mean, if it's acute mesenteric ischemia, they're getting a CT. Chronic mesenteric ischemia, if they have an aortic balloon pump, they got heart issues going on, so they're more worried about
More
taking care of that, then they'll do this on another time. So you might see elevated velocities in younger patients, so if you're doing this on a younger patient, just keep in mind age plays a part of that as well. So in terms of correcting, so post surveillance for mesenteric ischemia, they're gonna try and revascularize, so they'll go in, do balloon angioplasty. Endarterectomy, maybe they'll surgically remove the atherosclerotic plaques, or they can even do bypass grafts to get around vessels that are completely occluded. The goal is to try and reperfuse the mesentery, the gut. Again, most common things are gonna be angioplasty or endarterectomy or atherectomy. About 20 or 40 patients could develop intimal hyperplasia after angioplasty, which could lead to restenosis. So if the patient does have a bypass graft or stent, the velocity criteria are a little bit different, but this would be something that posted in your vascular lab. They would have criteria for diagnostic criteria after stent placement. So if they do have a stent or angio or a graft, the criteria is a little bit higher for, considering a stenosis. All for mesenteric ischemia. That's not bad.
That's a lot of information.
A lot of. Look at that.